What I'm going to do is give you an update on osteoporosis treatments. And I've given you a list here of all the treatments we now have available. I'm not going to talk about them all, but I'm going to focus on those highlighted. So that's simple calcium and vitamin D supplements. We've already had a bit of discussion on vitamin D, so further clarification of that in a moment. Obviously, I'm going to talk about bisphosphonates, because that's what we use most of all. And we got several different bisphosphonates, and I'm going to talk about them all. And we got oral and IV, and then we got a new anti-resorptive denosumab, which is a really interesting new drug, so I'm going to spend quite a bit of time on that. Also, a few brief comments about teriparatide, which is the only truly anabolic treatment we have for bone. And then lastly, I'll say a few words about strontium ranelate. As you're probably all aware, there are lots of new safety issues with strontium ranelate. So simple calcium vitamin D. So this is combined calcium and vitamin D supplements. That's your best treatment for your frail elderly patients. So those in institutional care, the housebound, lots of them, most of them are going to be vitamin D deficient. They're going to have some secondary hyperparathyroidism. And we know from studies over 20 years ago that we can reduce the risk of hip fractures and other non-vertebral fractures by about a third with simple combined calcium and vitamin D. So about 1 gram of elemental calcium, 800 units of vitamin D3. And we've got chewable supplements. We've got caplets now, which I think has enhanced adherence compliance, and we've got liquid formulation. So you've got several different options. Important message here is that if you give vitamin D alone, there's pretty consistent evidence you are not going to reduce the risk of fractures in that patient population. You have to give combined calcium and vitamin D. Where else would you use it? Well, you would use it as concomitant treatment. So if you're giving someone alendronate, for example, you would often also want to give them some calcium vitamin D supplements. Not everybody needs a calcium supplement. You can tailor that to the dietary calcium intake. And if someone's got a very good calcium intake, say they're drinking a pint of milk or more per day, you don't need to give them a calcium supplement, but you might still want to give them a vitamin D supplement. Some of the beneficial effects of combined calcium and vitamin D are on bone, and we have evidence for that. But also, there are a couple of randomized trials suggesting quite strongly that we're also reducing the risk of fall. So it's probably a combination of those two effects. So that's calcium and vitamin D supplements. So what about bisphosphonates? Because that's what we use most of all in the majority of our patients. And they're anti-resorptives, so they're osteoclast inhibitors. They will reduce bone turnover in general, they reduce bone remodeling. They will lead to an increase in bone density, and they reduce the so-called remodeling space, and they enhance or lengthen what we call secondary or passive mineralization. So you get more mineral and a rise in bone density. And thirdly, you preserve the structure of the bone, the microarchitecture of the bone. Put all those three together and the bone is stronger. Now, we've got several bisphosphonates from which we can choose one. And that then begs the question of, are they all the same? And I think the answer to that is no. And there are various potential determinants of efficacy, as I've listed here. Things like how strongly do they bind to the bone surface, how strongly do they inhibit the osteoclast enzyme, things like convenience, tolerability, IV versus oral, and so on. So you could rank your bisphosphonates in order of efficacy with the best at the top. And that's what I've done. And at the top, I would put intravenous zoledronic acid, and I'll try and justify that in a moment. Second, I would put the other intravenous bisphosphonate, ibandronate, and I think in general, there's some data, some head-to-head data, oral versus IV, to suggest that that is true. Then I'd rank the 3 amino bisphosphonates together, equal efficacy. That's alendronate, risedronate, and ibandronate. Then off the bottom, etidronate, and that's not so effective. So why have I put IV zoledronate at the top? So it's just 5 milligrams once per year. It's an annual infusion. Well, this was the fracture trial, a well-powered trial, 7,700 patients. And if you look at those fracture reduction rates, they're very good. And when we saw these data the first time, we thought, well, goodness me, we've never seen data as good as this. It's once a year, IV infusion, game over. Very impressive fracture reduction. However, we then started to see a nephrotoxicity signal. and that is a limitation of the treatment, and indeed below eGFR of 35, it's officially contraindicated. And you've got to be careful with patients on diuretics, people with impaired renal function. You do run the risk of worsening renal impairment. You've also got to ensure your patient's vitamin D replete, or they're going to get crashing hypocalcemia. Also, there are big logistical issues. It's an intravenous infusion, and mostly that's going to have to be given in secondary care. I know not always, but often. The other big trial with zoledronate is this, and this is a post-hip fracture study. So these are men and women who've had a hip fracture, and they're randomized to zoledronate or placebo within 3 months after that hip fracture. And you see on the left a significant reduction in all clinical non-vertebral fractures, and on the right you see a very interesting 30% reduction in mortality, which we think might be related to immunostimulation mediated through gamma delta T cells, and perhaps, for example, increases the resistance to infection. On the downside, I'm showing here post hoc analysis, and this is a downside that applies to bisphosphonates in general, is that when you look at older patients, there's a bit of a tendency to see efficacy become less convincing, and perhaps particularly for hip fractures. And we sort of saw it for risedronate, and we see it again for zoledronate. So if you look at people over the age of 75 and look at hip fracture reduction for them compared with younger patients, it's lower. And there's a significant interaction with age, and you lose statistical significance for reduction in hip fractures in older patients. And that's a bit of a concern, bearing in mind most of these fractures are obviously going to occur in patients older than this. On the plus side, and again this has led to a change in clinical practice, is that we have studies again from Ian Reid, the same group that looked at those meta-analysis for calcium, his group in New Zealand, have shown that after a single infusion of zoledronate, so this is just one infusion, you have a very prolonged effect. For at least 3 years, your bone density will go up and stay up, and your bone markers will go down and stay down. So increasingly, I see a patient who may not have severe osteoporosis. I give them a single infusion of zoledronate. I can then discharge them from the clinic. I'll rescan them, say, in 3 years' time. And I think that's an attractive approach that a lot of us are now adopting. So it's very long-acting. And you also have some post-hoc data showing that a single infusion of zoledronate, in terms of fracture reductions, if you look at the original RCTs, is just as effective as giving 3 infusions, which is what was planned in those original trials.